faculty presenter for today's session. Dr. Christopher Stilla is a professor of pediatrics and section head of general academic pediatrics at the University of Colorado School of Medicine and Children's Hospital of Colorado. He leads a very active group of roughly 60 pediatric faculty, practices, and teaches primary care pediatrics and conducts pediatric health services research and quality improvement focused on improving systems of care for children and youth with special health care needs in the medical home. He has a particular interest in improving coordination of care between primary care clinicians, subspecialists, and family members. He has led projects funded by U.S. Maternal and Child Health Bureau, the Robert Wood Johnson Foundation, the Lucille Packard Foundation, as well as and local and regional funders to pursue this investigation. Since 2019, he has been principal investigator of a MCHB-funded national network to conduct healthcare system research for children with special healthcare needs. Dr. Stilla is a member of the executive committee of the Council on Children with Disabilities of the American Academy of Pediatrics. Dr. Stilla, I'm going to turn it over to you now. Thank you.
Great. Thank you very much, Amy. And good morning, everybody. I hope you're staying healthy, but even more importantly, sane this summer and being able to have a little bit of fun from time to time. We're going to talk for the next 15-20 minutes about just a few things that we've learned from our telemedicine journey within our big complex care clinic. No rocket science, just a few things that are a little bit different from telemedicine and primary care. And also know that I'm doing this through a primary care lens because that's what I've done for most of my career. I have nothing to disclose, and let's go to the next slide. So the program that we have that I'm going to talk about is our Children's Hospital Colorado Special Care Clinic. We're a very large outpatient clinic for kids with medical complexity. We see almost 5,000 kids. That includes some healthy SIDS as well, but probably 80% of kids are medically complex. We do primary care as well as co-managed care with outside pediatricians, and there's a little bit of differences in telemedicine for that. We're going to talk about patient and family factors as well as system factors for telemedicine differences, some of the benefits, which many of you have experienced over the last few months, and some of the challenges that have yet to be resolved. We'll also talk at the end, sooner or later, believe it or not, COVID will go away, and we'll talk about what might stay and might go after COVID. Next slide. So I told you a little bit about our special care clinic. We take care of kids from at least 7 states, although the majority are from within a half-an-hour drive of Aurora, Colorado, which is right outside Denver. About 80% of kids have medical complexity, and many of those kids are able to graduate within a few years. Next slide. So we did very, very little telemedicine before the whole beginning of the shutdown in mid-March. Less than 3% of our visits were telemedicine. We were able to, with the help of our hospital, quickly ramp that up for at least half, maybe a little bit more than half some weeks of telemedicine visits, keeping in mind that even with that, our total visits were only about half of what we do on average. Usually March and April are our busiest months because of the end of flu season and other things. And this year, you know, like most other programs, our volumes only went down to about half. Once things started to open up again in mid-May, the number of telemedicine visits went down, as did the proportion. And now we do about 10 to 15% of telemedicine visits. Maybe that's a little low, actually, but that's how things are. And actually, I just got numbers yesterday that our volumes are back up to about 100% of average, so that's good. But it was quite the bump. We see telemedicine actually as being a good potential reserve in case we need to go back to more distanced care. And so we're keeping that in the back of our minds, trying to keep up in practice and not forget how to do it. Okay, next slide. We do it primarily through a connection with our electronic health record, which is Epic. There's a compatible software called Video, and they basically connect to each other. So we're able to open the connection from within our electronic health record. We have a few exam rooms. Right now we have 3 exam rooms within the clinic that are dedicated to telemedicine because they have a good microphone, a good camera, 2 screens, and a good internet connection. The 2 screens is really helpful because especially with complex kids, it's nice to be able to write some stuff down while you're looking at the family, and to have access while you're working with the family to different things like lab tests and imaging and other visits. So so that's I think one of the things that we've learned is have 2 screens when you can if you're going to do telemedicine. The other thing that 2 screens allows you, although you can do it with kind of an inset of 1 screen, is that if you have any sort of multidisciplinary needs, and when I say multidisciplinary, I mean not only other specialties, but nutrition, care coordination, interpreter services for families who don't speak English, they can kind of pop into the visit on the same screen and the family can see what you see. The way we do that is by having a secure messaging system that between providers. So when we're ready for another provider to pop in, we just send them a secure message and then they take a minute or 2 and pop in. The biggest thing that I think we couldn't do without is our medical assistants have been really great. They've been trained to do a technology check about 30 minutes prior to the visit with the family, both for audio and video, because sometimes you can get video and no audio. Less commonly, you can get audio but no video, and obviously you need both to work. Next slide. Next slide, please. Okay, so the challenges that I just mentioned, the challenges that I just mentioned are common to other telemedicine things. So, you know, whether it's kids with medical complexity or not, the technology is there. There are, not surprisingly, inequities, mostly due to access to high quality internet bandwidth, as well as high quality audio and video. Doing it by a phone on the family's end can sometimes not be ideal, especially if you want to do some physical exam things. And kids in rural areas also may have less access to good bandwidth. Obviously, families, patients, providers need to adapt to the new systems, and if they're already struggling with a system of care that might be different from what they've experienced in the past, that's just even more adaptation. There are some documentation differences. It'll be interesting to see that a lot of those the regulations have eased up because of COVID, but once they start to come back down, it'll be interesting to see if those differences really are a big issue. Right now, they're not so much. And the same thing with payment differences. Our state actually just had mandated that telemedicine be paid by payers that are operational or that are based in Colorado, whether it's Medicaid, CHIP, or even commercial insurances that are based in the state to pay for telemedicine, but that's not the same in every state. It's also not the same with big national commercial insurers that may not be as responsive to state regulations. Okay, next slide. So here's just a quick vignette about how we might use telemedicine. Typical kid that we see in our complex care clinic. LS has a genetic syndrome, severe dystonia, anxiety, and global delays. All of LS's visits have been challenging in the past, all of their in-person visits that required an adaptive care plan created by Child Life just to get through the visit. So even in person has been challenging. And in fact, at times, pre-medication, depending on their mood and any procedures that need to be done, have been used just to have the patient get through a physical exam and in and out of the clinic without things happening that we didn't want to happen. Next slide. So LS was a great telehealth candidate. They were relaxed, they were happy, it was not the clinic. The family felt better and was more able to attend to things. And really, this was her usual behavior at home. So it was great to be able to see her and not worry so much about what happens, because our only experience had been in clinic before. It wasn't quite as rushed. Everybody was able to focus. The visit, actually, we were able to get more things accomplished in a shorter time. So it was kind of like a virtual house call, although we couldn't do a physical exam very well, or immunizations or anything as part of that. Next slide. So no meds were needed. Communication was much, much, much better. The emotional health of the family, we were very reassured by that. On the other hand, we couldn't do vital signs, although we were not able to do a blood pressure in the vascular clinic anyway, so that was not a huge loss. Physical exam, you can see what you can see, but that's about it. And although we could run the parents through the type of exam that we would do to assess the patient's tone, you couldn't really get the feel and the proprioception that we get when we're able to do that part of the exam. Next slide. So distance is another thing. If families have to take several hours to get ready to come in, to have the visit, to go home, and then to unpack, that's a lot of time. And in complex care, many times patients come from a much bigger distance than they would otherwise. If we can do multidisciplinary televisits, that's even better. Depending on the specialty, that is easier, harder, sometimes impossible, but we're getting used to that. Obviously, the exam requirements are different, although I've found that with a good video connection and a kid who's cooperative, I can look at a G-tube just as easily by a televisit as I can in the office. The influence of the home setting, sometimes it's negative, sometimes it's positive. Many times it's positive, although it depends on what other distractions are there. If there are other kids, other family members, we've all experienced dogs, airplanes, sirens, things like that. And then, the last thing is, for kids who are super fragile, sometimes in-person visits can be a little bit risky, and that's mitigated through a televisit, plus infection issues. Next slide. The time requirements are a little bit different with the system also. There's more time required ahead of the visit with a televisit, and a little bit more preparation, especially in terms of time from MAs who are taken away from their other tasks to do the tech checks. On the other hand, many of us have found that the actual in-visit time to accomplish the same number of things is sometimes a little bit less, and not usually more. So that's good. We talked about the multiple team members. We talked about the payment. Again, so far it's okay, at least with our experience with Medicaid and the insurers that are based in Colorado. And the other biggest thing too is interstate regulations. We have a lot of patients from other states. And for example, Wyoming has fairly liberal regulations in terms of being able to do telemedicine. Primarily because they don't have as many, they don't have a referral center for kids, and they don't have as many pediatricians. So they're more liberal about that. Other states are much harder. For example, we can't do any telemedicine with kids from Nebraska because you have to have a license to do any telemedicine in that state, which basically makes it impossible. And the other thing is, that malpractice insurance often doesn't cross state lines. So that's a policy thing to keep in mind for the future. Next slide. Just another vignette with maybe a little bit more challenges. WO it has trisomy 9, has a trach, is dependent on a ventilator, has had a lot of admissions, and lives 4 hours away. In Colorado, but 4 hours away. So when WO was discharged from the hospital, we set up a telehealth visit. The visit was great because the home care nurse was able to be present as well, which enabled really fast review of the home care orders and medication, which we often do on a separate call. So that was good. If the medications are there in the home, we can just, have the parent show them to us, and so we can get pretty accurate medication reconciliation. That was good. But it did require a lot of coordination with everyone to be there for the visit. Next slide. No travel required. It's 8 hours just of driving for WO's family, not to mention all the prep time to get them into the car. Able to have a conversation with the home care nurse, like I said. She was able to check vital signs, which is one thing that we get lost sometimes in telehealth. And then this was a little bit later. This I think was late April, beginning of May. So we're sort of more used to having multiple people on the call. And our special care dietitian and psychologist were able to just pop in a little window to participate really pretty seamlessly, and actually with less time in between. So that was good. On the other hand, WO required some lab work, and we were not able to do that. So we'll have to set that up from their hometown. And what's not possible in their hometown is the x-rays and the other imaging that are needed, that really need a pediatric center to be able to do that. So we'll have to roll that into a visit this summer. Next slide. So I've been talking about this a little bit. It's definitely less risk, less time commitment for the families. I've noticed that with the kids that I've done, sorry, my screen just blacked out. Here we are. Is that kids, for example, kids with autism and kids with anxiety disorders are usually less anxious with a telephone visit. And overall, notwithstanding the cost of the technology and the cost of the MA's time, overall, the system probably has a decreased cost. We haven't really specifically looked at that, but just sort of back of the envelope, it seems to be a little bit less costly. And then finally, on our end, from the distancing that we need to do from one another because of COVID, we can accomplish that with a multidisciplinary clinic by telemedicine. Next slide. So we talked about technology, bandwidth at home. The language barriers, we have in-person Spanish interpreters, and many of our providers and team members speak Spanish. But if families speak neither English nor Spanish, that's much harder, especially if they come from a culture that is not highly technologically savvy and a health system that's different from ours. That makes it a lot harder. Obviously, any exam is dependent on video quality, and it can't be complete. So for example, well childcare is hard because you need to do a good physical exam. You need to do screenings like vision and hearing, and those really aren't possible through a telemedicine thing. So well childcare is probably the biggest hurdle. It's the same as, with not kids without medical complexity, but it's just hard, and you can't do shots. The other thing that we've run into is that there was a higher no-show rate for in-person visits, but there was also a higher no-show rate for telemedicine visits, and we're still trying to look into that. I don't know if others at other institutions have experienced that. It's getting better as the summer goes on, but we're still scratching our heads about that one. Next slide. So we think that follow-up visits by telemedicine will continue post-COVID because they tend to be less dependent on physical exam. We can kind of pick and choose what follow-up visits need to be done in person, but those will probably be many of the things that will stay. The other huge win is follow-up with our integrated behavioral health clinician. Obviously she does not need to do a physical exam. She can benefit very much from working with the family in their own environment. And so those will stay as well, assuming funding. And then any of the multidisciplinary things that are not as dependent on the exam, like nutrition, where you need to get an accurate height and weight, but maybe the parent can do that. Pharmacy visits, where the bulk of the thing is medication reconciliation and discussing drug interactions and what might need to be stopped or modified. So those things will likely stay. Next slide. So then there's sort of the question that nobody knows the answer to is, are we going to have more virtual visits in the future? Is it going to be more than the 10 to 25% that we're seeing now? We don't know. I think we'll need, the biggest thing that we need with that is family input. Assuming this again, and I can't stop saying this, is the resources to support it. whether it's payment, whether it's technology, whether it's staffing models that might be a little bit different. Next slide.